let's move on to its regulation and control. Okay. So the production of active calcitriol is meticulously controlled by a sophisticated hormonal network, ensuring calcium and phosphate levels remain within a tight physiological range. So the first player here is the parathyroid hormone. Okay, this is like the village head, okay, the sarpanch. A decrease in plasma calcium levels, which is also called hypocalcemia, is the primary stimulus for the parathyroid glands to release PTH or parathyroid hormone. Think of low calcium as a distress signal and PTH as the village head rushing to coordinate a response. PTH acts directly on the kidney to dramatically stimulate the expression and activity of 1 alpha hydroxylase enzyme, which is, if you recall, present in the proximal tubule cells. This leads to increased calcitriol synthesis. PTH also decreases the activity and expression of CYP24A1, which further boosts calcitriol levels by reducing its breakdown. In addition, PTH directly increases bone resorption, which means releasing calcium and phosphate from bone, and enhances renal phosphate excretion, all aimed at raising serum calcium. Increased calcitriol in turn enhances calcium absorption from the gut, calcium reabsorption from the kidney, and mobilization of calcium from bone, all working synergistically with PTH to restore calcium homeostasis. This is a vital team effort to prevent symptomatic hypocalcemia. The next player is calcitriol, which is 125 OH2D, right? This is like the deputy chief of the village, okay? This deputy ensures things don't go overboard and that resources are not overutilized. High levels of calcitriol directly inhibits the synthesis and secretion of PTH from the parathyroid gland. It also directly suppresses the expression of CYP27B1, which is for 1 alpha hydroxylase in the kidney, thus limiting its own synthesis, and powerfully induces the expression of CYP24A1 for the 24 hydroxylase enzyme, thereby promoting its own catabolism and reduces its active concentration. This is a crucial self-regulatory mechanism to prevent hypercalcemia and potential toxicity. Then there's the Fibroblast Growth Factor 23. Okay, this is like the finance minister. Okay, it's a major phosphate regulator. Primarily, it is secreted by osteocytes in bone in response to elevated phosphate levels, hyperphosphatemia, or high calcitriol. So FGF23 is like the finance minister, keeping a strict eye on phosphate levels and preventing their excess. FGF23 acts on the kidney to exert its effects. It directly inhibits CYP27B1, which reduces calcitriol synthesis, and it stimulates CYP24A1, which increases calcitriol breakdown. Critically, FGF23 also promotes phosphate excretion by the kidneys by downregulating sodium phosphate cotransporters in the renal tubule, thus preventing hyperphosphatemia. So, FGF23 is a key player in phosphate homeostasis, and its intricate interaction with vitamin D metabolism highlights the sophisticated interconnectedness of calcium and phosphate regulation. In conditions like CKD, chronic kidney disease, elevated FGF23 is a major driver of vitamin D deficiency, and it contributes significantly to something called renal osteodystrophy. Now, phosphate levels, let's just talk a bit about that. High phosphate levels can directly inhibit 1 alpha hydroxylase activity, independent of FGF23, which adds another layer of control to prevent excessive calcitriol production when phosphate is abundant. So, this intricate dance of hormones ensures that calcitriol levels are precisely tuned to meet the body's needs, preventing both deficiency and toxicity. It's a perfect example of biochemical jugaad to maintain physiological balance. Primary and most well understood significance of vitamin D. The foundation of its study is its crucial role in calcium and phosphate homeostasis, which is absolutely critical for strong bones. So, intestine or the gut is where calcitriol is the most potent stimulator of intestinal calcium and phosphate absorption. Calcitriol is the most potent stimulator of intestinal calcium and phosphate absorption. It dramatically increases the absorption of dietary calcium and phosphate from the small intestine, primarily by upregulating the expression of specific proteins, which we won't be talking about. This is its most significant and rapid effect on calcium balance. In the bone, it promotes the mineralization of the bone matrix, ensuring that newly formed osteoid, which is unmineralized bone matrix, is properly hardened and strong. In conjugation with PTH, parathyroid hormone, it regulates bone remodeling, which is the continuous process of bone formation by osteoblasts and resorption by it regulates bone remodeling, which is the continuous process of bone formation by osteoblasts and resorption by osteoclasts. This ensures old damaged bones are replaced by new healthy bones. While calcitriol can stimulate osteoclast activity indirectly at high concentrations or directly in concert with PTH, its overall physiological role is to maintain bone health by ensuring adequate mineral availability for proper mineralization. In the kidney, it enhances the reabsorption of calcium and phosphate in the renal tubules, preventing their loss in urine. Calcitriol upregulates calcium channels and pumps in the distal convoluted tubule for calcium reabsorption and influences phosphate reabsorption in the proximal tubule. However, discovery of VDRs in virtually every tissue type throughout the human body has unveiled a much broader biological significance, establishing calcitriol as the true Bahubali of biochemistry. Let's just see, other than these primary organs which we study about in most books, where else is vitamin D valuable with the new research? So the first is the immune system modulation. So calcitriol is a powerful immune modulator which influences both innate and adaptive immunity. It enhances the antimicrobial activity of macrophages. It modulates T cell differentiation and cytokine production, generally reducing pro-inflammatory responses and promoting immune tolerance. This explains its potential role in managing autoimmune diseases like type 1 diabetes, multiple sclerosis, rheumatoid arthritis, etc., and influencing susceptibility to various infections. Next is cell growth and differentiation. Calcitriol has anti-proliferative and pro-differentiating effects on various cell types. It can inhibit the uncontrolled growth of cancer cells, example breast, colon, prostate, lung cancer, and promote their maturation into more specialized, less harmful forms. This suggests significant roles in cancer prevention and as an adjunctive therapy. Next, in cardiovascular health, emerging research strongly links vitamin D deficiency to an increased risk of hypertension, heart disease, and stroke. Calcitriol can regulate components of the renin-angiotensin-aldosterone system, or in short RAS, improve endothelial function, reduce systemic inflammation, and improve arterial stiffness, all contributing to overall cardiovascular well-being. Then there's brain function and neuroprotection. So VDRs are found extensively in the brain, including areas involved in mood, cognition, and motor control. Vitamin D has been implicated in neurodevelopment, neuroprotection, and maintaining cognitive function throughout life. Deficiency has been linked to depression, cognitive decline, and an increased risk of neurodegenerative diseases like Alzheimer's disease and Parkinson's. Then, in metabolic syndrome and diabetes, studies suggest a significant link between vitamin D deficiency and insulin resistance, also impaired pancreatic beta cell function, and an increased risk of developing type 2 diabetes. Calcitriol can influence both insulin secretion and insulin sensitivity in peripheral tissues. Then there's the reproductive health. So VDRs are found in reproductive tissues, example ovaries, uterus, and testis. And vitamin D may play a role in fertility, also pregnancy outcomes, example preeclampsia, gestational diabetes, and maintaining reproductive health. So, in essence, calcitriol acts as a crucial signaling molecule integrating diverse physiological functions to maintain overall health and cellular integrity. It's not just for bones, it's for life itself, acting as a multifaceted protector. Okay, so now we have a good biochemical insight and a broad overview of the functioning of the vitamin D molecule. Next, let's do some clinical connections, okay? So, let's bring this biochemistry to the ward round and see how it translates into real patient scenarios, which you'll encounter every day in India. This is where the rubber meets the road, actually, where knowledge becomes treatment. So, this is the first clinical case. So, this is the scenario. You're in a pediatrics rotation at a district hospital. A 2-year-old child from a lower income family in rural Uttar Pradesh presents with bowed legs, okay, delayed walking milestones, and a potbelly appearance. On physical examination, you notice prominent costochondral junctions, which is rachitic rosary, widened wrists and ankles, and general irritability. The mother mentions the child is exclusively breastfed and rarely taken outside. So, first, let's see the biochemical correlation. This is a classical presentation of Rickets, which is a severe vitamin D deficiency in children, specifically affecting the growing bones. Without adequate calcitriol, intestinal calcium and phosphate absorption is severely compromised. Despite the parathyroid gland trying its best to maintain serum calcium levels, there isn't enough mineral to properly mineralize the newly formed cartilage at the growth plates. This unmineralized osteoid accumulates, causing the characteristic bone deformities like bowing of long bones, widened epiphyses, and growth retardation. The pot belly might be due to hypotonia of abdominal muscles. So, rickets, though preventable, is still prevalent in India, particularly in infants exclusively breastfed by vitamin D deficient mothers, or in children with limited sun exposure due to cultural practices, urbanization, prolonged swaddling, or even air pollution blocking effective UVB penetration in crowded cities. Next, we have the second case, okay? So this is the case of an elderly woman. Okay, so the scenario is a 65-year-old woman from a bustling Delhi neighborhood who spends most of her time indoors watching some Saas Bahu serials, presents to your general medicine OPD with chronic generalized body aches. Along with this, there's muscle weakness. She complains of difficulty climbing stairs and presenting kamar dard, which is lower back pain. Her desi nuskhe, which is home remedies and local malish, uh, which is massage, haven't provided relief. Her 25 OHD report comes back at 12 nanograms per ml. So let's go with the biochemical correlation. This sounds strikingly like osteomalacia, the adult equivalent of rickets. In adults, since growth plates are fused, bones don't deform in the same way as in children. Instead, existing bone fails to mineralize properly. This leads to the accumulation of unmineralized osteoid, resulting in soft, weak bones, diffuse bone pain, often worse with weight bearing, increased risk of atypical fractures, example loser zone on X-ray, and characteristic proximal muscle weakness or myopathy, which explains her difficulty climbing stairs. Elderly individuals are at high risk due to multiple factors: decreased skin synthesis of vitamin D3 with advanced age, reduced dietary intake, and sometimes impaired renal function affecting the crucial 1 alpha hydroxylase activity. So, the reality is, many elderly Indians, especially women, have limited outdoor activity due to various reasons like mobility issues, fear of falling, cultural norms. or even a desire to avoid sun exposure for perceived skin darkening. This, combined with diets often low in fortified foods, makes them highly vulnerable. This is a common yet often misdiagnosed cause of chronic pain in our geriatric population. Then the final case here is the renal failure patient. Okay, so this is the scenario: a 50-year-old man with end stage chronic kidney disease who has been on hemodialysis for 3 years presents with severe bone pain along with generalized itching and recurrent pathological fractures. His serum 25 OHD levels are surprisingly within the normal range, but his parathyroid hormone levels PTH is sky high, and his serum calcium is persistently low with high phosphate. Okay, so coming to the biochemical correlation here, this is a classic case of renal osteodystrophy, which is a complex bone disorder seen in CKD patients. Even if he gets enough vitamin D from sun or supplements, his failing kidneys cannot perform the crucial second hydroxylation step. The damage occurs to renal tubular cells, and the impaired 1-alpha hydroxylase enzyme prevents the conversion of 25 OHD to 125 OH2D, which is calcitriol. This leads to profound calcitriol deficiency, severe hypocalcemia, and consequently massive secondary hyperparathyroidism, because the parathyroid glands overwork to compensate for low calcium, which further exacerbates bone disease. Here, giving native vitamin D3 won't help much as the kidney cannot activate it. He needs active calcitriol analogs like alpha calcidiol or calcitriol itself directly. So the reality is CKD is a growing public health problem in India, driven by the rising prevalence of diabetes and hypertension. Understanding this specific biochemical defect is vital for effectively managing the complex bone and mineral disorders in these types of patients. A common challenge in nephrology units. Now we come to the assessment of vitamin D status. So, which tests do we actually do? Okay. So the gold standard is, when you order a vitamin D test in routine clinical practice, you're looking for 25 hydroxy vitamin D or 25 OHD. This is the best indicator of overall vitamin D status. It reflects both skin synthesis and dietary intake, because it is the main circulating and storage form for a relatively long period, like 2 to 3 weeks, and its plasma concentration directly correlates with total body vitamin D stores. Its levels are less affected by acute fluctuations in sun exposure or food intake. The question could come here is, why not 125 OH2D, which is calcitriol, for routine assessment? So measuring active calcitriol is usually not useful for assessing general vitamin D deficiency. Why? Because its levels are tightly regulated by PTH. In early or moderate vitamin D deficiency, which is low 25 OHD, PTH will rise to stimulate renal 1-alpha hydroxylase, often maintaining 125 OH2D levels within the normal range or even slightly elevated. As a compensatory effort, this masks the underlying deficiency. It's only in severe prolonged deficiency or in cases of renal failure that 125 OH2D levels fall significantly. So measuring calcitriol or 125 OH2D is typically reserved for specific diagnostic situations. Example: suspected primary hyperparathyroidism, renal osteodystrophy, or vitamin D dependent rickets. Now the reference ranges, these are rough reference ranges. They may vary depending on the lab or the population. Okay, so the deficient level is less than 20 nanograms per ml, and this requires treatment. Then there's the insufficient range, which is 20 to 29 nanograms per ml. This stage usually requires supplementation. Then there's the sufficient range, which is 30 to 100 nanograms per milliliter. This is the target range for optimal bone and overall health. Then there's the toxicity range, which is more than 150 nanograms per ml, typically from excessive supplementation and not skin exposure. Now, a couple of key risk factors for vitamin D deficiencies. Okay, this is like the identification guide for Indian clinicians. Okay, so the first one is darker skin pigmentation. So it's melanin's natural sunscreen effect is at play. Then the second is limited sun exposure. Okay, so urban lifestyles, indoor occupations, culture, religion, etc. Then third is the elderly population. Okay, like we discussed, decreased skin synthesis capacity, etc. Then there is obesity. So vitamin D is fat soluble and it gets sequestered in adipose tissue, which reduces its bioavailability in circulation. So obese individuals often require higher doses of supplementation. Then there is malabsorption syndromes. Conditions like celiac disease, Crohn's disease, cystic fibrosis, or post-bariatric surgery states interfere with fat absorption, thus reducing the absorption of fat-soluble vitamin D. The sixth one is chronic kidney disease. Impaired 1-alpha hydroxylation is a direct cause, right? Then there is chronic liver disease. So severe liver disease can impair 25 hydroxylation. Then finally, certain medications like anticonvulsants and rifampicin can increase vitamin D catabolism by inducing hepatic cytochrome P450 enzymes. Glucocorticoids can also interfere with vitamin D metabolism and calcium absorption. So now we have come to the end of this topic. I would like to just summarize this, okay? In high yield summary bullets for your exams and clinical practice, okay? So the first one is vitamin D is a pro-hormone, okay? Not just a simple vitamin. Its active form is calcitriol and it's a powerful steroid hormone. Next, the complete synthesis pathway, okay? So it begins in the skin, proceeds to the liver and culminates in the kidney, okay? So I'm not going into the depth of that because we have talked about it multiple times. Then there's the rate limiting step. Okay, the rate limiting step is in the kidney by 1-alpha hydroxylase enzyme. It's the most crucial and tightly regulated step. Then biological active form is calcitriol or 125-OH2D. Okay, it exerts its effect by binding to the nuclear VDR, which then forms a heterodimer with RXR to regulate gene transcription at specific vitamin D response elements. The key regulatory hormones are PTH, calcitriol, and FGF23. The main enzyme for inactivation is 24-hydroxylase. The primary functions are, it is essential for calcium and phosphate homeostasis, which enhances intestinal absorption, promoting bone mineralization and increases renal reabsorption. The extra calcimic roles are plentiful, right? Extensive functions beyond bones include immune modulation, anti-TB activity, autoimmunity, regulates cell growth and differentiation, which has an anti-cancer potential, cardiovascular health, neuroprotection, and metabolic regulation. Clinical assessment is always measure 25-hydroxyvitamin D to assess a patient's overall vitamin D status, as it reflects total body stores. The deficiency, surprisingly common in India despite abundant sunshine, leads to rickets in children and osteomalacia in adults. The toxicity is rare from sun exposure alone, typically occurs due to excessive under supervised oral supplementation. Remember, understanding this pathway is not just about memorizing enzymes. It's about connecting the dots between the elegant logic and intricate design of how our body maintains balance and responds to its environment. It's about being a smart doctor, okay, not just a bookworm. Okay, thank you for watching the entire video. Hope you all got some information and insight into vitamin D. Hope to see you in the next video. Thank you for watching.